going to do another video here on EMresource.org. Redone the menu a little here, so we're going to go to resource pages, and then I have my favorites asterisks here, so we're going to do decision rules. All right, so decision rules. So also called clinical criteria, decision criteria, tools. I don't think rules is a great term because rule means you have to follow it. So this is a little bit of, I guess, my spiel on that sort of thing. So most of these shouldn't really be rules because there are always exceptions and you don't always need to follow them, but they are good guidelines in general. So guidelines would be another term. There's so many different things we could call this. Another important thing that I think most lecturers, when they talk about this, they don't include the exclusion criteria for the study. And that's really important because that's almost part of the rule. Those are people you can't apply the rules to. So in all of these sections, and this is organized head down, I'm going to have exclusion criteria highlighted in red. So we're going to start with the head with the PCARN rule. I think this is a great rule. I almost use it for adults too. I mean, typically this doesn't cover blood thinners and stuff like that. So these are who is included in the study. So that's the number of patients, 42,000, their age, GCS, and this is sort of what they ended up having, like 5% had a positive CT, 1% traumatic brain injury. Clinically important, I think that is, and about 1 in 1,000 needed surgery. Now, important, they excluded ground level falls, presentations over 24 hours. I think they excluded ground level falls and walking into objects because those are considered sort of trivial mechanisms. Prior CNS disease, probably because you couldn't do a good neuro exam and a penetrating injury. Now, this over 24 hours, for me, like this is where, tool rule comes in handy. A lot of people come in over 24 hours because something is getting worse. And the fact that they come in after 24 hours, sometimes that is a red flag. But there's other people who come in after 24 hours and they're doing fine. It's because they talked to a friend or there's some other reason. Someone told them to go in and it's not necessarily a red flag. And the fact that they're still doing fine 24 hours later is actually reassuring. So this group, I think, is pretty heterogeneous. So, I think all these other exclusions don't require a lot of thought, but this one I think does. So I would say most of the people I see over 24 hours, I would say have even lower risk because they're doing fine and they're there for a not concerning reason, but certainly worsening pain or worsening symptoms would be concerning. Here's some of the abbreviations. Each section in this page is sort of organized like this. So these are some abbreviations you need to know in case you don't know what PCARN stands for. I have some charts below reproduced. So basically there's sort of two branch points on these charts. The first is if they're altered or they have an abnormal neuroexam or evidence of a skull fracture, that's really high. The risk of an injury is over 4%. Just CT those. Branch 2, the risk is about 1% if any of these other factors are present. So these are, I have a mistake here because AMS is here as well too. So let's see. Yeah, I should take that out. Anyway, so these are other things, and if basically I like this because they give you a little bit of clinical judgment here. They're saying if any of these is present, it's about 1%, and then sort of use your gestalt. But obviously, if more than one is present, or if one of these symptoms are present and getting worse, this doesn't ask like if there's a headache, is the headache getting worse? So we talked about altered, concerning mechanism, loss of consciousness more than 5 seconds, a palpable fracture, a non-frontal hematoma, vomiting. So these are all red flags. The more that are present, the more severe they're present, the higher the risk. So if you have multiple of these and something's getting worse, that patient is probably way more than 1%. But if you have only one of these, say they've only vomited once and they have a little bit of fever, maybe they have a stomach flu, and the mechanism's trivial. I've certainly had cases like that where the patient has headache and vomiting, trivial mechanism that you don't think, they roll down some carpeted stairs perhaps, you don't think it's going to be anything bad. I might watch those people, and a lot of those kids, they'll develop diarrhea, and the vomiting has nothing to do with the head injury. And then the benefits, so how much CTs were decreased by, risk of cancer from a CT estimate, has it been validated, here's the two charts. So that is the pecan rule. So staying with head, we've got Nexus 2, and they also excluded delayed care over 24 hours. Here's a little mnemonic or criteria they used, and sensitivity, benefit, how many scans they got rid of. There's a Canadian head CT rule too, so we've got a bunch of head rules here. Also MIPS, I don't know if a lot of you are having to do this MIPS stuff, but that's not really a rule, but it is something published by the government, so I think, it could be used medical legally or sort of as a rule for not doing CT. And then I have my own mnemonic that I kind of like, hematomas, and it's got a bunch of different things. It's hard to remember all these, but once you've been doing this clinically, as you're asking stuff, you find out more and more red flags. So if you're doing a good history. So this is a good mnemonic because it's easy to remember, hematomas, and it's got, I think, mostly one thing per letter. Oh no, there's two for A. Okay, so next we're going to go down to the Nexus C-spine rules. I've really seen more and more people doing CT scans on the neck for almost everyone, and I think it's a shame because they're all negative. Anyway, this was who needs a plain film of the neck, and I use this a lot to clear clinically. And one thing that I think is important, so these are the people who are excluded. Again, that's always important to know because people don't talk about this. Number of patients, number of fractures, the criteria, no distracting injury. So this one, basically the way I do it is I ask the patient while they're lying there not moving, do you have any pain right now that's so severe you think it would distract you from something else being broken? So basically that should be, I think, the definition. No one's ever taught me that. They just sort of gloss over that one, but I think that is important. So that's how I operationalize this one, because it's a little more subjective. We've got the Canadian C-spine rules too. I think these two rules sort of complement each other. I sort of mix factors from both of them. So those are here. PERC criteria. I have a good mnemonic here for the PERC criteria that includes these exclusion criteria. So no one ever talks about these exclusion criteria. I think the PERC are good, and you're probably going to exclude someone with cancer, but that was excluded from the study. It's not listed in one of their criteria here. Beta blocker use. I think certain calcium blockers too, so that could prevent tachycardia. And I think it's important that, if you get close to 100, I think you should just consider tachycardia. For me, I typically use over 90 for most people for tachycardia rather than over 100. And then the main exclusion criteria for PERC is if you have medium or high clinical suspicion. So in my mind, that means you have to have another diagnosis that's more likely. It really sounds like bronchitis. It really sounds musculoskeletal. So these are super important for the PERC criteria, and they're not included in the criteria. So, but they are included in my mnemonic, which is A, B, C, D, E, F, G, H. So we've got the pulse, and I said I use 90, not for everyone, someone who's maybe obese or out of shape or something like that, but I think you should pay attention. 99 is basically the same as 100. Age. So here's one of the exclusions for B. I have no beta blockers, no cancer. Those are actually not part of the criteria. Those are exclusion criteria. Scan is an old school word for leg. So that is PERC criteria. And then also in some of these, I've included blind spots. So I think this is more important when we get to the hard criteria. This is basically the same as the exclusion criteria for PERC. Now the chest, I think more and more people, we're still on chest for PERC criteria, the years criteria. So I think more and more people are aware of this and using it now. So this is basically, D-dimer is too sensitive. So when can we use a twice as high cutoff for D-dimer, so we're scanning fewer people. And this has been validated, and this is who they excluded, age under 18, blood thinner use, and the mnemonic is HAD, so no hemoptysis, no better alternative diagnosis, and no DVT. So patients, or no clinical signs of DVT. So patients who have none of these and are not on blood thinners, you can use, if your normal cutoff for D-dimer is 500, you can use 1,000. If it's 250, you could use 500. And the sensitivity was around 99%. And then blind spots, I don't have any. And then sometimes I have some links to the articles. Hard score, I think there are very good and bad things. I've done podcasts on hard scores. Excluded are patients without pain, so other STEMI equivalents weren't necessarily included. The main thing I think is important for the heart score is the blind spots. So if you have had chest pain that has resolved and lasted less than 30 minutes, then you should know your EKG and troponin are pretty useless. And you could have someone with a really concerning story, exertional chest pain lasting 5 minutes. That's classic for unstable angina. And they could have a really low heart score, but I don't think the heart score is sensitive enough. I think it needs to be applied carefully. I think it's good to use to protect yourself if you want to send someone home that you really think can go home. It's good to get someone admitted if you're getting pushed back from a hospitalist, but it's bad when the hospitalists use it to prevent admitting someone. They'll say, well, this guy's got a heart score of 2 or 3, but the history is classic for unstable angina. They just have a normal EKG, normal troponin, maybe they're not that old. So I think it's super important to be aware of this blind spot. And in my medical malpractice expert witness work, when I see MIs that get missed, this is one of the big categories, is unstable angina. So I wouldn't use the heart score for those kind of patients. And then another thing that's important is, this idea of the average. So if you have a heart score of 0 to 3, the risk is about 2.5% for bad outcome in the first 30 days. If you do a second troponin, you might be down to less than 1%, but second troponins are only useful when the pain lasts probably more than a half an hour. So some people, the second troponin doesn't really decrease the risk at all. It just gives you false reassurance. But all these numbers, 0, 1, 2, and 3, probably don't have the exact same score. Probably a 3 is significantly higher risk than a 0 or a 1 or a 2. So some 3s, I think, definitely are going to be higher risk. Because once you get to 4 to 6, now the risk jumps to 20%. So it's not like a 3 has a risk of 2.5% and a 4 has a risk of 20%. This would really be sort of a line, and then you're pigeonholing or you're grouping them together. So I would really like to see a heart score. What's the risk for 0? What's the risk for 1? What's the risk for 2? What's the risk for 3? What's the risk for 4? Because this is going to be more of a linear pattern. However, it's organized as a step like that. So I think that's a big blind spot as well. But yes, it's validated. Let's see, we got more for chest. So I think we're going to finish up here. More chest stuff. We're still on chest. Curb 65. I think this is one of the dumbest rules ever. Someone with pneumonia who's confused, I'm going to admit, BUN over 20, I don't think matters that much. Now, if they're clinically dehydrated, I might want to admit them, but I think this is useless. Respiratory rate over 30, I'm not going to send someone home with a respiratory rate of 30 or a blood pressure over 90 over 60. I'm not going to worry that much more if someone is 66 if they're really healthy compared to a different age. I think some of these are so worrisome. Like these two would be super worrisome, or a lactate greater than 2. I mean, maybe if you repeat it and it's lower. So my opinion is this score is pretty useless. I mean, I guess you could use it to push for an admission or to justify sending someone home, but I think, I think this is a crazy rule. I don't know how that got popular. We got some auto and knee and ankle foot rules. Okay, so those are the main ones. So again, this is in the EMresource.org website, the resource pages, number 2 decision rules. I hope you use it. Share it with your friends, and thanks for listening.